everyone. I am Nadia Kamal. I am in charge of health tech and innovation at Harmonie Mutuelle. It's the first company of insurance for companies in France. And I am particularly in charge of investment in funds, not in startup, but in funds in healthcare. I am today with Madeleine Durand and Jordi Ferrer, and I let them to introduce. Madeleine, first.
Thank you, Nadia, and hi, everyone. I'm Madeleine. I'm head of strategy for the insurance business of Bupa in the UK. So Bupa is the largest health insurer in the UK market and the only one that has a network of provision services, including clinics, dental clinics, and a hospital, as well as care homes, so a really comprehensive healthcare company. Been working there for the past 9 years, doing several roles across strategy and innovation for several of our businesses. And my background is management consulting, so strategy is my passion, and always excited about the new and changing things that come into our market. So really happy to be here.
Jordi?
Thank you, Madeleine. Thank you very much. Well, my name is Jordi Ferrer. I'm from Barcelona. I'm an economist by training, father of 2 kids, and I currently work at Ship2V Ventures, which is an impact venture capital fund based out of out of Spain, Barcelona. It's an impact VC because we have 2 verticals. One is healthcare, the other one is climate investments. I am responsible of the healthcare investments, in which the impact angle we give to it is that rather than being focused on specific pathologies or specific technologies, we rather are focused on specific population types. And we invest mainly in solutions that help improve quality of life of elderly people and people with chronic diseases in a direct and measurable way. And I think this measurable way gets very well with the theme of today's panel.
For this session, we choose together the aim is health prevention and data-driven. And I ask the first question to Madeleine and Jordi. Could you explain in UK and you, Jordi, in Spain, healthcare model and healthcare ecosystem for our patients? Madeleine?
Happy to start, yes. So as many of you probably know, in the UK, the healthcare market is dominated by the national health system. So it's government funded, it provides universal comprehensive care coverage, it's free at the point of care. Now, this means that the vast majority of the patients, and up until a few years ago, it was almost all of the patients, would start their healthcare journeys within the national health system, as it was their GP that would then direct them for onwards care. Now, over the past few years, the private healthcare sector has grown steadily, both on the provision side and insurance. And this was supported by the growing healthcare demand on the back of the pandemic. In terms of healthcare data, one would think that the UK is in a really privileged position with the fact that so many healthcare journeys start and stay within the national health system. However, as you probably have heard earlier in other panels, the data landscape remains very fragmented, and there's still lots of opportunity in connecting that data better and linking it in to unlock more powerful, especially prevention strategies.
Yeah. I mean, Spanish ecosystem is, or healthcare system is pretty similar in the sense that it's vastly government paid. So the 70% of the market is basically the government. Then there's a 25% that would be private, but insurance private, which is a little bit different and also heavily dependent in the governmental one. And then there's a 5 or slightly less than 5% that is purely private. I would say that in addition to this, it's not centralized. Unlike the NHS or other countries that is completely centralized, we have different regions that manage different healthcare systems that are independent one to the other, which back to the data issue and reimbursement issue, and I mean, it really adds a layer of complexity to the system, because it's not the same being taken care of here in the northeastern part of Spain, in Catalonia, than being taken care of in the south or in Madrid, in any other region. So it is governmental, but it's, there's, let's say, autonomy in different regions. To add a little bit to what Madeleine just said, I would, and I think it's relevant to bear it in mind, I would say that the system, the current system, is roughly 60 years old right now, and it was settled at a time where all the environment was completely different, right? So to start with, most of people was getting sick because of acute diseases, not chronic diseases as today. The expected lifespan was 20 years less than today, so roughly 60 years old. Today is roughly 80 years old. People were getting retired at 65, the same age. So the life expectancy was lower than the retirement age. Now it's 15 years more, and this also puts a lot of pressure into the sustainability of this system, absolutely. And indeed, we are, I think we have a very, very good healthcare system, but it's facing huge challenges. And the reality of the society as we live it nowadays, and I didn't even mention the pyramid, the age pyramid, right? So the population is getting older. So this system is definitely being threatened by challenges, and we need to address them. So we definitely need to take care of the system, otherwise it won't last long.
We have the same problem in France. And regarding prevention, how do you work with prevention side patients and side insurance and payers in UK and in Spain in objective to limit care?
Yeah.
I'm happy to go. So just to remain around the private sector, what I found really interesting, and I'm a firm believer in prevention, and it's something that I've always tried to integrate in strategies in the work that I've been doing with different teams. But up until the pandemic, I think those conversations were few and far between across the sector. And it's been fascinating to see how things ramped up massively over the past 3-4 years. And prevention went from a nice to have to being almost an imperative. And I think some of the reasons, Jordi, you mentioned just now, are very much behind it. So there is obviously the need to rethink a system that is becoming really imbalanced in terms of supply and demand. We won't have enough capacity to cure everybody who needs care at one point. But there's also the fact that people have become a lot more health conscious after the pandemic, which has also driven people to look for more solutions and find more available. So it's created a really virtuous circle, but also, of course, the ever-expanding costs of healthcare, which mean as well that we must rethink how things work. And as far as payers go, there's several initiatives that have started to be put in place. There's things along health and well-being, and some health and well-being programs that have started being offered to customers. Most of them are digital, and they're really helpful tools and a great option for people to access preventative services. But then there's more targeted initiatives as well, whether it's around primary care and easier, faster access to both digital GPs or physiotherapy services, mental health, and those help a lot in terms of keeping costs down and diagnosing people faster and helping them to manage some conditions earlier on before they need more severe intervention. But of course, as well, when it comes to cancers, like faster and easier access to diagnosis and better targeting of treatment are several things that have been put in place.
I mean, fully agree. I mean, prevention is something that everyone knows that works, but no one is doing.
Nobody
right?
does.
No one is doing. Not on a. I mean, as I was speaking about the system earlier, because the system is made so the system triggers when someone is sick, not before that, right? So first of all, no one is making money out of prevention. And this is already a burden to it. But also, at a population level, we are usually not conscious of the risks, not as individuals nor as institutions, of the risk of not preventing. So I would say prevention, the way it's taken care of right now is that it's an important word that everyone knows and knows it's important, but it's not taken care of as it should it's actually, I would say, most of prevention measures are either out of voluntarism, so even social assistance, people that are assistively taking care of people that are at risk, but that are very not included, let's say, in the social system, or it's mostly private. It's mostly private. Then if we go into monitoring, precision medicine, companion diagnostics, these more, let's say, sophisticated tools of which are also ways of prevention, we are starting to see them. But again, we enter into, I think probably this is the way that we're seeing the most penetration in terms of prevention through these more sophisticated treatments that are either representing a huge benefit, a huge differential outcome into the patient, or a huge direct and short-term saving to the system, because when the saving is long-term, it's a different story. But this is probably the way that we are seeing most prevention, yeah.
And do you have one example of in your deal flow?
Well, yes. I mean, in our, as I said, our fund, we are only investing in companies in which we can measure the outcome directly. So I would say all of them, but in the sense that I was saying, I would say probably the most relevant example is Sikai, which is Sikai Medical, which is a tool, an AI tool for radiologists that is able to identify cystic lesions in the pancreas, so pancreatic lesions. So it's before they tumorize or before they malignify. So from a scanner that could be, for whatever reason, there's already an algorithm that is screening, proactively screening for potential lesions that could malignify in the future. So I think this is a very good example of how technology or data could be used in cases in which the disease is not even suspicious, and we could prevent not only the course of the disease, but we could prevent the disease per se. So this could be probably the most relevant example. And then we have others.
And do you have some example in mental health?
Excuse me?
In mental health.
In mental health, we do have examples in mental health. Actually, one of our portfolio companies from Germany is a psychological assistant, digital psychological assistant to cancer patients. And there's a lot of evidence. This company has evidence on their own, but there's also other evidence that the levels of adhesion to treatment, rehospitalization, quality of life in general, anxiety, so on and so forth. All these indicators are lower when you are taking care of mentally well in such a disease than when you're not. So this would be.
And you, Madeleine, do you have some example of prevention apply or at Bupa?
I have first a more general reflection. I agree with you, Jordi, that measurable here is really the key word. And where we have the best examples is where you can measure them. And this tends to be in secondary prevention. So in people who already have either high risk factors or some initial symptoms. And yes, we've seen amazing results there. And you don't need to go very far. Even something like physiotherapy, giving access to treatment to people faster before they need their GP intervention and then being directed to more specialized care and surgery, that massively reduces how many people need surgery. So it's not something, we're not using entirely new tools, and it doesn't sound really exciting, but it does have results. However, it's really important that we move towards a setup where we can have better primary prevention as well. And like you say, Jordi, to what everybody knows what's right, nobody's really doing it. Why? Because there is never certainty around the results. I mean, we all think maybe we'll live a healthy lifestyle, but then, do we really know what the result of that is on an individual level? And for a company, how many companies have clients that stay with them long enough that they can claim that they see the return on investment for primary prevention? Not that many, but mostly it's still very, very generic. There isn't real personalized prevention. And when we can address people with action plans that work for them and for which they can have a degree of certainty that they will avoid developing certain conditions, then that will change the game. And genomics might be a really good way to address this if done in the right way. But there is potential, but I think we really need to unlock prevention at another level.
Yes. Yes, it's a hard work for prevention, and I agree with you for secondary prevention. For the prevention and for the action, do you think it's better to work with a population, a group of population, a cohort, or pathology-based? Jordi, perhaps?
Excellent question. I would say the combination of the two. There are some. I mean,
with your experience with
when we talk about when we talk about changing from fee-for-service to outcome-based, in my mind, I always I'm seeing more of a capitation model rather than fee-for-service model. So in this case, depending on what you want to prevent, on what you want to. What is your objective, one will be better than the other. If it's all about prevention and keeping a certain population type safe, for instance, elderly people, a population-based approach would be appropriate. And actually there are models, interestingly, and I've seen them in the US, for instance, that are paying healthcare companies, healthcare institutions for their insurees that are kept healthy. So they are being paid only for those that are kept healthy. Now, if you are entering into a different type of pathology or an injury, for instance, or some type of surgery, then of course you do have to move into pathology-based, and you have to move towards better recovery times, better recovery levels, and in these particular cases, it would be wiser to move to pathology. So I would say that depending on what you want, one would be better than the other one.
But for the Q cost, you think there is a better one, or we have to mix the both?
For the, excuse me?
For the Q cost.
To reduce the cost.
To reduce the cost.
To reduce the cost.
I mean, so to me, what works best to reduce costs is the outcome-based approach, and then you will use a pathology-based one or a population-based one, depending on what you want, what the outcome you want. But both would be usable depending on what the outcome you want. And then I used the two examples, whether you want to keep people healthy or whether you want a faster recovery. And I think these two, in these two cases, one would be better population-based, which is taking care of the elderly one, and the other one would be more pathology. I think that the real compromise here is to find the good combination of the two of them.
Okay.
Yes, and I agree that by changing mindset, then you can really make some important choices in terms of what type of prevention you're going to use where, bearing in mind what is your end goal,
Absolutely.
What it is that you're trying to achieve, and the outcome to the patient above, anything else. So yes, it's definitely a combination of both. You can't put all your eggs in one basket and prevention.
And in UK, you think there's a mix of the two?
Absolutely.
Yeah.
I think this is one where, irrespective of the health system, the outcomes that we expect to see are the same. It's just different ways of achieving them based on your infrastructure and people's preferences and habits when it comes to healthcare.
Okay. And then the last question for the conclusion, what is for you the best way to have best prevention for the patient, for the payer, and for everyone?
I mean, for me here, really the key thing is collaboration. I've been sitting in the room earlier today, and I heard so many people mention the fact that, there's a lot of frustration around data silos, how much, we know how much we can do with data, and yet we can't seem to find the best way to bring it all together and unlock the potential. And this is not a problem that we can each solve individually. So this is one that definitely calls for greater collaboration and more strategic partnerships.
Yeah, I would say it's a matter of aligning incentives, right? So the current system has completely different incentives for different stakeholders. Payers have certain incentives, practitioners have other type of incentives, even time frame incentives. So I would say if we all agree into that the outcome is the important thing, and we align incentives for all the stakeholders, then the solution will come naturally. And we do have the data. We do have a ton of available information and available tools to make a dramatic change. I think it's about starting with changing the incentives so they are all aligned, and then the change will happen automatically, because we do have all the data and we do have enough basis for better outcomes.
Yes, for us in France, for me in France, and for Harmonie Mutuelle, prevention starts, continue. But the French government, perhaps we will have another one this night, but it's very hard to start to understand the business model, to choose in which way we can advance and we can reduce costs. It's very hard in France for me. And thanks everyone, and have a nice afternoon.
Thank you.
Thank you. Thank you, everyone.
Thank you, Jordi and Tchèque. Thank you, Madeleine.
Thank you very much. That was excellent. And now we move on